Hey, Omis, welcome back to the I Believe podcast. Today I am joined by Dr. Mehmi from the Angels Clinic and Research Institute in California. Dr. Mehmi, thanks so much for joining us.
Thank you. Thank you for having me. It's great to talk to you again.
Yeah, I'm super excited. I feel like I've heard a lot about you, especially in the last year, just from like some of the friends that I have in the pharma companies, and I'm super excited to hear what you guys are doing at the Angels Clinic for uveal melanoma. But can you just tell us first about how your profession as a medical oncologist intersected with uveal melanoma in the first place?
Right. After undergrad, I was interested in cancer research. Didn't know what path I was gonna take, a researcher or a healthcare provider. So I worked at UC Berkeley National Lab for about a couple of years and got some, you know, research experience under my belt, and that made me realize I definitely am a people person. I need to be around people, and with however help I can provide them with. So I ended up going to med school, and eventually, after finishing my residency, and was hired at WVU Cancer Institute as a medical oncology provider. And my focus was supposed to be breast cancer at that time, because that's where the need was. But along the way, within about a year of my employment, one of our medical oncologists who had been doing melanoma and other malignancies of cutaneous origin ended up leaving, so they needed help, and that was the starting point. After that sort of seed led to my interest in melanoma. That led to establishing a ocular oncology program with the help of the ocular oncologist at the WVU Eye Institute, and I've never looked back since. And been here at the Angeles Clinic for about 6 years now, and continue to work very closely with Dr. Hamid, a world-renowned melanoma oncologist. I've learned a great bit from him, and now sort of trying to spread my own wings within the ocular oncology field.
Yeah, absolutely. So I want to just clarify, in the Angels Clinic, do you guys have ocular oncology and medical oncology? Like you have the ability to kind of send people around to both?
So we do not have a dedicated ocular oncologist, but we do partner with some of the ocular oncologists that are available at UCLA, at
Okay.
USC, and Dr. Zach Oki out in Pasadena area. So there are a number of providers, ocular oncologists that we work very closely with and able to see their patients on a very expedited manner. And I think one of the benefit of the Angeles Clinic is that the availability of number of clinical trials at any given day that we're able to offer to our patients with, various different types of malignancies, especially, uveal melanoma.
Yeah, absolutely. Well, this is something that, we want to touch on for sure. In the West region, if patients are looking for care, what kind of access to those clinical trials would they have? I guess let's go ahead and start with the clinical trials since you mentioned that, and then we can go back to kind of more standard of care FDA approved options.
Right. So, within clinical trial setting, our goal always is to make sure we cover all spectrum of stages of disease, right? You want to make sure that there are adjuvant options for high-risk patients, and if there are any neoadjuvant research going on, we make sure either we bring the trial here, I'll find a place where some neoadjuvant studies are going on in ocular oncology, and we know there's plenty of movement there. And then for first line and for later line therapy, talking about Replimune versus, trying to expand on Chopin study, or looking at some late line therapies with bringing on external IITs from Dr. Tarhini over at Moffitt. His trial is available at our site. And then we have a number of phase 1, phase 2 trials that actually, when we pick them, we make sure they allow, uveal melanoma on there, because a lot of the trials that are offered from the industry, they tend to exclude most of the uveal melanoma patients.
No, that's such a good point. Okay, so if patients wanted to learn kind of more about actively recruiting clinical trials at the Angeles Clinic, where would be the best place for them to start to get that information?
So, I mean, typically what I ask most of my patients to sort of access is reliable sites, right? You don't want, um, typically Google doesn't work. So you want to go to clinicaltrials.gov website. You want to go to our website where it lists all the number of trials that we have and their brief description, whom to contact. And then, my email is very, very accessible online, and you can just hit send, an email to me where I can help you decide, if there is something available that fits that patient's need versus, I have a number of colleagues within this area. I work closely with Dr. Moser, work closely with Dr. Chmielewski at UCLA. So the 3, 4 of us, we partner and we find the need for the patient, whatever is needed for whatever line of therapy that they're at. We're trying to figure that person out and help sort of, locate that clinical trial to get that patient on.
Yeah, absolutely. Okay, so I love that we just jumped right into treatment options. So the treatment options of clinical trials obviously is there, and I love that you covered, we've got the neoadjuvant setting as well as the adjuvant, and we've talked about those terms before. So guys, if you have questions, head back to some of those previous episodes that we've done. What do you have like in terms of the current like FDA approved treatments that we have specifically for uveal melanoma, like Hepzato-Kit and Kimtrack?
Right. So we'll start with Kimtrack, right? Kimtrack's been approved, and I'm pretty excited about Immunocore actually getting ready to present their 5-year survival data at AACR in about 2 weeks.
Yeah, I think it's coming up super soon.
Exactly. So I think everybody should be tuned in and look at that. And this is the therapy option available in the first line setting or untreated metastatic uveal melanoma patients or unresectable uveal melanoma patients who are HLA-A201 positive. I mean, we've seen the first line data. They came up with the 3-year overall survival data, and now they're going to update that data for 5-year. We know the very typical toxicity that tends to happen within the first 3 weeks, very predictable for most of the patients. And after that, the therapy is very well tolerated, and there are a number of patients that will actually benefit for a long term. So that option is available, and a lot of the local oncologists actually will use our expertise to take the patients through the first 3 doses, which is the dose escalation portion of this treatment. And once the patients are stable and doing well, then we return them to the treating oncologist or referring oncologist, and they continue the therapy locally. So they're not bound to come to us on weekly basis. They could be at home and visit their oncologist that's within 15, 20 minutes, hopefully. So I think that's a really interesting option that we're able to offer. And then obviously in standard of care setting, we also have the expertise and the experts available to take patients through the hepatic perfusion therapy, PHP, from Delcath. And we also are applying the early phase data from Chopin, which is ex-US trial looking at combination of Ipi-Nivo with PHP, showed remarkable responses, very good overall survival at 1 year. So I think that data is very exciting, and Delcath is looking at to sort of expand onto that. So I'm actually very fan of that trial. Granted, there's a significant amount of toxicity that we have to mitigate, but again, something that everybody's very excited about.
Sorry, can I ask you about the toxicity? So I know that especially in the uveal melanoma world, I mean, I've been a patient for coming up on 6 years, and I have heard about Ipi-Nivo basically from within the first few months of my diagnosis as like, oh my gosh, avoid it at all costs. As an oncologist, what would you say, especially given the Chopin protocol, about managing the toxicity? Because I think the important thing is that it is manageable.
Absolutely. I think when we were young in Ipi-Nivo space, right, about 10 years ago, we didn't know how to recognize these immune-mediated adverse events. And a lot of the time we chalked it up to infection or this and that, and we weren't apt at recognizing that these are actually immune-mediated toxicity. And now we're relatively older in that Ipi-Nivo space. We know how to recognize these toxicity, and we know how to manage them, and we're finding newer agents to mitigate those toxicity. For example, a lot of the patients, one of the most common toxicity from ipi/nivo is pruritus or dermatitis, right? We'll try topical steroids. We'll try low dose oral prednisone. If none of those are working, we'll try Claritin. We'll, number of different options that are disposable, that are easy to take, not a lot of side effects. But there's a small group of patients that still can't be managed from that perspective. Their pruritus still bugs them. They can't sleep at night. The newer agents actually are helping, like Dupixent, we'll get the dermatologist to use it for that, and very effective. And so I'm just trying to say that we are getting much better at managing those toxicity, not just recognizing them. So when I hear avoid ipi/nivo at all costs, I think for some patients, if that's the only option, you should not be thinking that I want to avoid ipi/nivo.
Yeah, absolutely.
That's even a bigger story in cutaneous melanoma, but we'll keep that on one side.
Yeah, absolutely. Okay, so I love that we can cover, some of these options. And I know you mentioned the Chopin protocol. Those of you guys listening, if you didn't tune into the liver or the Chopin webinar that we covered, the Chopin protocol and the trial data, please go back and listen to that. It's going to give you so much hope. But like Dr. Mehmi said, I mean, the data in this trial was astounding, for lack of a better term. And it really just showed that there's a lot of power in combining the immunotherapy with Hepzato. Are you seeing, have you been using that protocol in practice, or is it like only a trial? I think that's kind of a question some patients have.
I think it is we've tried it for a couple of patients. Granted, it's a small subset of patients that underwent. There are a few questions around the trial as well, and how disease was evaluated, extrahepatic disease versus intrahepatic disease. I think there's some questions, but the data is still very valuable. And because of the toxicity issues, both from ipi/nivo and from hepatic perfusion, you got to select these patients very carefully, right? Because PHP will lead to a certain degree of, bone marrow suppression or cytopenias. And on top of that, some GI toxicity, nausea, vomiting, and whatnot, fatigue, weight loss, appetite changes. And some of that can overlap with ipi/nivo. And you want somebody who can tolerate that sort of added on toxicity. So we're very careful in selecting these patients for that combo approach. But yeah, definitely something we've done it here, and look for patients who are excellent candidates for that.
Awesome. Okay, so we've covered clinical trials. We have our FDA approved, like uveal melanoma specific treatment options. Do you guys have other liver directed options, systemic options that you offered to patients kind of in lieu of trials if things are not recruiting, or, if it's just a better situation for that patient? What other options do you guys have?
So we work very closely with two groups of interventional radiologists here at Cedars-Sinai. The medical center in Beverly Hills and Providence St. John's, and both sets of interventional radiologists are very good at helping us out, getting the patients in quite quickly for any sort of liver directed therapy, either ablation of any sort, cold, hot, ethanol, and also chemoembolization. All those procedures are still available and at our disposal. And we continue to use them for the appropriate patients. In addition to that, for some of the patients, if we're kind of running against the wall and nothing's available, we'll rely on the old faithfuls like Timodars or dicarbazines and things like that for kind of like extend whatever time we can for our patients.
Yeah, absolutely. So I've actually never heard those terms. You said Timodars, and I'm gonna let you say it again.
Temozolomide or Temodar, it's an oral chemotherapy that's given for about 5 days out of the 28 days, and has about 20 to 30% response rate. Not very durable, but for patients who don't have much options, we tend to use those, that particular. The carbazine or DTIC is the IV formulation of the same drug. Efficacy is very similar. Adverse event profile is very similar to Temodar. But again, for patients whom I cannot find a clinical trial for, or they're not a candidate, and we've run out of other options, we fall back onto the old chemotherapy and trying to help those patients.
Okay, so it sounds like overall, you and your oncology team at the Angels Clinic have focused pretty heavily on expanding the uveal melanoma oncology care program within your region. So why do you feel like this is particularly important for where we live in the States? Like I know I'm in Arizona, so like I'm also in the West.
No, I think uveal melanoma is still, I mean, it's a disease that we need to learn a lot about. Once we know more about it, then we can find options to treat it. So what I would say is, I think for any medical oncologists that are out in the community, or any patients that are diagnosed with this particular disease, I think we need to get them seen at a high volume center to increase the funded knowledge and also sort of have these treatment options made available to them. Not a lot of these clinical trials are available at every site or every different place, because uveal melanoma is such a rare disease. It is hard for all clinics to invest into it. Right? Cannot sort of designated resource for this small subset of patients. And so that's why, we work closely with UCLA, USC, and also UCSD, UCSF, for example. Like all of us, we get on calls every, once a month on a Monday at noontime, and we go through some of the trials that are available at each site, and we talk about how to kind of have these patients get access to these trials. And I think that that sense of community in a small area, it's small by, from a sort of area perspective with large population. And we're just trying to make sure that every patient has appropriate access to these clinical trials so they can reap the benefit of it. And we can continue to learn and have answer to this disease that still is fairly difficult to treat.
Yeah, absolutely. So kind of jumping off that idea of like why we want to have treatment options available, especially in the region. I know it's always kind of heartbreaking to me sometimes when patients are telling me like, oh, well, I only can go to the East Coast. And I'm like, no, you have so many other options. So this is part of why I love chatting with the doctors who are at centers like the Angels Clinic. And I have done, a lot, obviously, with my doctor, Dr. Justin Moser, because we want patients to understand there are treating medical uveal melanoma medical oncologists who have expertise in the area. I think it's really important to distinguish the fact that somebody who has this kind of clinical trial awareness, who's involved in the research, who's collaborating with other doctors across the country, like those are the doctors that are going to be best for a uveal melanoma patient versus like just the oncologist who happens to have a uveal melanoma patient, but like maybe they've never treated one before. They've never even heard of the cancer before. So do you feel like it's particularly important to make sure that even if you live kind of out of the way, a couple hours, that as a patient that we seek care from a medical oncologist who has more expertise in the field?
Absolutely. Coming through my training, my, attendings used to say that if you'll see maybe one uveal melanoma a year, just to let you know that this disease exists. But if you 3 or 4, then you're an expert. Now, and I think there's some truth to that, because this is such a rare disease that, a lot of the time, a liver biopsy comes back as melanoma, right? And so, and we know that the treatment options for cutaneous melanoma don't really benefit the uveal melanoma patients a whole lot. So it is important to have a patient who is suspected for, metastatic uveal melanoma, to have them talk to a provider and a medical oncologist who's seen a number of cases. Dr. Moser is a great example for that. Dr. Chmielowski, myself, so and we've seen various presentations. We know, what the different nuances of treatments are, and how to recognize the adverse events that come from Kimtrack or hepatic perfusion, all those things. So I think it just, helps, even if the patient remains with their original treating oncologist, that having a conversation with an expert will only benefit the patient. You know,
Yeah,
and
absolutely.
I think that's for both the community oncologist and for the patients.
Yeah, I think it's so important. And I feel like I've talked about this from like day one when I first like bribed Dr. Moser to come on the podcast with me, like probably 4 or 5 years ago. Um, so I think another kind of misconception or kind of commonly held belief that I think that the community at large of ocular melanoma patients is maybe kind of holding on to is this idea that we don't have very many good standard of care options for metastatic disease. Do you agree with this, or do you believe differently given the emergence of like Kimtrack, Hepzato Kit?
I I think we're still in the middle of that. I don't think, I mean, when you're looking at its counterpart, cutaneous melanoma, right? We're boasting about 5-year survival, 10-year survival, off treatment, patients
Mhm.
not getting treated at all, and all those things. We're not there with uveal melanoma. Not at all. So I think we're sort of in the early stages of getting there, but we will get there.
Mhm.
But I don't want, uveal melanoma patients to think that they're not good options for them. We have options. We just stopped, talked a few minutes ago that Immunocore is updating their 5-year overall survival data with Kimtrack. And it well, how long did it take us to get there? Years,
Mhm.
right? We didn't talk about 5-year survival about any FDA approved options for uveal melanoma. And now we're talking about, so we're, taking those small steps, but they're definitely in the positive directions. And then we have PHP, we have ipi-nivo for some of these patients. And then Replimmune's doing amazing work with RP2 and Nivo together. Um, Amadix is on its way to establish amazing data for some of the HLA positive patients with their adoptive T cell therapy. So, I mean, and on top of that, there are a number of other early phase clinical trials looking at, targeted PI3 kinase pathway in uveal melanoma. And some of the antibody drug conjugate options are coming up in trial options. So, I mean, I don't think that a patient should leave with the thought that they're not, adequate options for them. I think there are FDA approved options. And on top of that, we have a number of different clinical trial options that just gives me hope every single day that we are going to turn the tide against this disease, and that's going to happen relatively soon.
Yeah, I think it's absolutely incredible. And it's so neat to like I think to be at a clinic where, you guys are a treating clinic as well as a research clinic is what I'm hearing from kind of the title and what you talk about. So is there an area of research in uveal melanoma that you're most excited to currently explore or that you're like excited to explore in the future?
Right. So we're always looking at some of the retrospective data, looking at, who's really getting help from these therapies, let it be Kimtrack or other. And we've been part of a number of those projects and looking at, is Kimtrack combining with another option able to help us more than just Kimtrack alone? And granted, all that is retrospective, but it's a signal that we can expand on later. And always looking at newer treatment options from looking at patients' tumor genomics, see if there are any mistakes that we can harness the power, for treatment options. So all the biomarker data that piques my interest at all times, and we continue to look at that.
Yeah, absolutely. Okay, well, I feel like this has been such a neat conversation. We've covered a lot, you guys. So if you need to go back and listen, please just, rewind the button on the YouTube channel or on the podcast. You guys can go back and listen. But for patients who are looking to get in touch or just are curious more about the Angels Clinic, you mentioned your email. So do you want to go ahead and share what that email is? And then also maybe we can just drop an info blurb in the description below.
Absolutely. So my email address is my first initial I, last name Mehmi, Mehmi, at theangelusclinic.org. You're more than welcome to share my information that is in the email. The email address is there. And our clinic phone number is 310-231-2176. We're able to accommodate quick appointments to help you out. So look forward to working with Danae on this topic and continue to help our patients.
Yeah, absolutely. Okay, last question. If patients are looking to come that direction, do you guys have the ability to do telehealth appointments?
Yes. So, the landscape of coverage and all that stuff is changing, but at the same time, I continue to do video visits with our patients who can't travel or who are from much further away, to at least if they need a second opinion or to just look over their records to see if the treatment steps that they're on are appropriate or something different we could do, or in the future, if I'm able to offer them a clinical trial. Yeah, absolutely. I continue to do televisits with the patients.
Awesome. Well, Dr. Mehmi, thank you so much for your time today. We could not do this without the physicians who come on to our podcast, who volunteer themselves to be like, hey, like I'm here, I'm treating patients, but also who just share your expertise and your compassion that you have for patients. We, like as a community, we really, I mean, none of us would be here without you guys. So we're really grateful to you.
Thank you.
I just want to also drop a big thanks to our sponsors. We have sponsors for the I Believe podcast and our YouTube channel, Delcath Systems, IDEA Biosciences, Castle Biosciences, and Aura Biosciences. You guys, our sponsors make this possible. They do a lot to help make sure that we are supported as a company, as a nonprofit who is, really trying our best to empower patients and continue leading the community, I think, in the education of patients and making sure we stay on top of things. So thanks for being here, you guys. Thank you again to our sponsors. And Dr. Mehmi, I would look forward to, having you back again. We can chat about something else.
Thank you, Danae. Take care.